Good evening, everyone. Thank you for taking some time on a Tuesday evening to kick off our 2026 Residency Hot Topics. I am very excited to welcome Dr. Jeffrey Giuliani to be our invited speaker for today. He is a world-class physician in all manners of orthopedics and sports medicine, and he's updating us today on meniscus repair. Dr. Giuliani, the floor is yours.
All right. Well, thanks, Ben. Thanks for the nice introduction and all of you taking some time out of your night to talk about what is really kind of some of the things that keep me up sleeping at night, dealing with some of our collegiate and professional level athletes. Meniscus repair techniques can be challenging, and this is a problem that seems sort of routine and mundane in the general population, but these things can go south pretty quickly. And so I'm going to talk through some of the repair techniques and then a little bit about the recovery. And then if you have any questions, we'll go through those as well. So next slide, Ben. So meniscus injuries are extremely common, over 222 per 100,000 person incidences per year. And the medial meniscus is more commonly torn than the lateral meniscus. And that's due to the fact that the medial meniscus has a very intimately relationship with the medial joint capsule, where there's not as much mobility as the medial meniscus, and it tears twice as commonly as the lateral meniscus. We do almost 1 million meniscal surgeries per year. You can imagine that the cost burden of the healthcare industry for this, it's over $4 billion per year. And as we all know, the risk factors come in two variables, the modifiable risk factors and the non-modifiable. So we can't do much about those non-modifiable risk factors, but the modifiable ones, where we look at our patients with higher body mass indexes, if they participate in higher level athletics, and then high burden occupations. Next slide. And so the meniscus is made up of fiber cartilage, primarily water. And as we get older, the water content goes down and the propensity for tearing goes up. The organic matter makes up about a quarter of the meniscus, primarily collagen, type 1 collagen. And its function is really for chondroprotection. It dissipates the axial load or the force transmission across the joint by increasing the joint congruity. And the lateral compartment of the meniscus, of the knee, the meniscus is much more critical because the lateral compartment is like a tennis ball on a dinner plate. There's no congruity there. And the meniscus creates this sort of ball and socket, more of a suction cup, to evenly distribute that shock across the joint and protect the cartilage. And so the meniscus is also important in stability, in proprioception, and it does lubricate and nutrition the joint. Next slide. And so this study out of the British Journal of Sports Medicine in 2019 was a systematic review, meta-analysis, looking at over 80,000 patients in a pooled demographic. And the take-home point from this study was that there's a 6-fold increase in the risk of arthritis after traumatic meniscal tears compared to the non-injured control groups. Next slide. And so the meniscal blood supply is actually quite tenuous. It comes from the perimeniscal capsular plexus, and that's from the outside of the joint capsule, and it's limited to the peripheral 1/3 of the meniscus. So the outer third's the red zone, the central third's the white-red zone where there's some blood supply, and then the inner third is the avascular white zone. You can see that in the histology slide on the right as well. Next slide. So the blood supply changes throughout our lifehood. In early childhood, the entire meniscus is vascularized. So as surgeons, we'll repair as many menisci that we can, even in the worst case scenario tears, because a lot of them still heal. By adolescence, it gets to be more of that adult pattern where the outer third of the meniscus has the blood supply. And so although meniscus repair is favored, and we still try to do that, central meniscal tears often need to be debrided versus repaired. And then in adulthood, the meniscus has very poor blood supply, and the meniscus debridement is sort of the treatment of choice. So looking at the anatomy, the menisci are shaped differently. You can see the medial meniscus is more of an oval shape. And as I said, it's attached to the medial capsule of the knee. And the medial collateral ligament is also intimately related to that meniscus. So there's not as much mobility of the meniscus, or forgiveness, if you want to call it, to axial loading. The lateral meniscus is more C-shaped, and in the back corner where it says ligament of Rissberg there's the popliteal tendon. And that popliteal tendon makes a gap between the meniscus and the capsule, and it has more mobility and is a little bit more protected from injury. Next slide. And so traumatic tears, they often have a specific mechanism of injury. I was skiing, I stepped off a curb. The symptoms are pain and swelling, and also mechanical symptoms where they feel like something's catching in their knee. The medial meniscus is more prone to cutting type injuries, like your typical sport injuries. A 30-degree flex knee with all the weight on there, and you do rotation and you get a medial meniscus tear. The lateral meniscus tends to be more of like deep squats, full flexion with a little bit of rotation. If you see a lateral meniscus tear in a younger patient, we also have to be thinking about normal anatomic variance, which is a discoid meniscus, where they have more meniscal tissue than the average patient. And so it's prone to tearing because there's extra tissue stuffed in the joint space. And in our ACLs, although there are association with medial meniscus tears in the chronically deficient knee, in the acute setting, ACLs are most commonly seen in conjunction with lateral meniscus tears. So the presentation of our degenerative tears are a little bit different. They're older patients. It can be insidious in onset with or without a mechanism of injury. I like to say it's like the last straw that broke the camel's back. The meniscus is deteriorating, and then finally one wrong step and that degenerative tissue tears. They can have either subacute or kind of chronic joint line pain. And believe it or not, most degenerative meniscus tears are asymptomatic. So I tend not to operate on a lot of degenerative meniscus tears. I'll try to exhaust conservative treatment modalities because patients can do quite well. Until they start getting intermittent swelling, mechanical symptoms, then I'll counsel them and consent them for meniscus debridement. You can see what a typical degenerative tear looks like here, where we just kind of vacuum suck and clean up the loose pieces of meniscus there. So on history and physical, joint line pain and tenderness is probably the most accurate physical exam finding that we have. Patients, again, they can or may not have swelling. Mechanical symptoms are very helpful in diagnosing the problem. And our three physical exam findings that help diagnosis is joint line tenderness being the most specific. McMurray's test, which on the top right, you basically put the knee in flexion to extension, alternating varus and valgus. And what you're trying to do is just catch the loose fragment of meniscus between the two bony ends, between the femur and the tibia. And then finally, the Thessaly test on the bottom left is where you flex to 30 degrees and they rotate their weight around their knee. Again, trying to catch like a hangnail, like a loose piece of meniscus between the two bones. Next slide. So this prospective cohort study kind of looked at that. It looked at 109 patients who had arthroscopic confirmed meniscus tears, and the number one complaint was discomfort and pain. About 50% of them had clicking or mechanical symptoms, so you may not see those mechanical symptoms in all meniscus tears. When you combine all three physical exam maneuvers, our chance of accurately diagnosing meniscus tears increases significantly. But again, the gold standard and the best way to diagnose meniscus tears is via MRI. Next slide. So imaging, it's a standard battery of x-rays. So we get a 4-view x-ray, and you want to, of course, rule out fracture. Look at their alignment. If the knee's in varus or valgus, that compartment that is compressed, or where all the mechanical axis weight is going over, the meniscus is more prone to tearing. In this top right x-ray, you can see how narrow the joint space is on that medial side of the joint. And so it's sort of a chicken and the egg phenomenon. When a patient has arthritis like that, they have to have a meniscus tear. And so we get referred these patients with bad arthritis that say, oh, your symptoms are the meniscus tear. And that's not, in fact, what's going on. It's sort of the joint is collapsing, and then the meniscus has to be extruded from that void, that space that is eliminated. And then if you look at the other x-ray here, that discoid meniscus I spoke about, there are some classic findings we see. You can see this patient is skeletally immature. The growth plates are open. And that lateral compartment where all those white arrows are coming from is widened. The condyle is squared off, it's widened. So imagine stuffing, 10 pounds of packing peanuts in a 5-pound space. You got extra meniscal tissue in there. And then an MRI, again, is modality of choice. And then this is just a few MRI examples of meniscus tears. A on this diagram is a typical horizontal meniscus tear, that white signal and the black bow tie there. B, you can see the white signal is more vertically oriented. In C, you can see the two black lines. The back most posterior line is the PCL. The one in front of it is actually a displaced bucket handle meniscus. It's called the double PCL sign. It's very common. And then finally, D, you can see there's sort of a stellate, like a sunburst pattern of signaling in the meniscus, and that's your typical degenerative meniscus tear. Next slide. And so we have to determine, is it an acute injury, is it a degenerative injury, and how are we going to treat it? And so it all depends on tear pattern. And so this is a great diagram schematic of the type of tears we look at. So the vertical longitudinal tear, which is far right on the screen there, yes, that's sort of the classic, easy to repair. It's in line with the fibers of the meniscus, the longitudinal fibers of the meniscus that go all the way around the meniscus, and these can be repaired. And you can imagine if that goes all the way around the substance of the meniscus on the bottom left, you can get a bucket handle tear where that piece is sort of flipped out of place there. The horizontal tears are on the top of the screen. That is sort of, there's a superior and an inferior leaflet to that tear. Usually that's a debridement situation where I take away the skinnier flap, leave as much meniscal tissue as possible. The radial tear, right where your arrow is, that is probably one of the worst actors of meniscus tears. It transects, goes across the longitudinal fibers of the meniscus, and just like the metal rings of a wooden barrel or rungs of the wooden barrel that keep the barrel intact, if you take those metal rungs away, you're losing the entire function of the meniscus. And some biomechanical studies have shown that a radial tear essentially renders the meniscus incompetent. You have the parrot beak tear on the top left. Those are just like hangnails, literally analogous to a hangnail where we debride those. Bottom right, the complex tear is that degenerative tear, which you can't really put sutures perpendicularly, so we debride those as well. And then the root tears are at the front and back root of the meniscus, and I'll go over that in a future slide. Next slide. Ramp lesions, you may hear of these. It's basically a peripheral injury affecting the posterior horn of the medial meniscus, often in the setting of an ACL tear, and they are very easily missed, but again, biomechanically devastating to the knee if you don't pick up on that. And so the bottom diagram is more of a sagittal view looking at that connection of the meniscus to the capsule. So it's not necessarily in the substance of the meniscus, but it's in that capsular meniscal junction. And if you miss that, and you'd have to look around the back of the knee with a special scope at a different angle, then you're really doing harm to the patient because it renders the meniscus again relatively incompetent. Next slide. This is the root tear I was talking about. The top screen is an arthroscopic picture of the back root attachment. 2 sutures have already been passed through it. I'm showing you the repair technique here where we basically put a luggage tag stitch, and then where those sutures are entering the cartilage, you see the bottom diagram, there's a vertical tunnel that comes out the front, and we tie those sutures over a button, and you can see we're anchoring that posterior root of the meniscus. Again, these are often seen in acute traumatic injuries, but you can see them in end-stage arthritis where the bones contact one another and the meniscus has no choice but to tear at one of those roots and get extruded. And those are bad actors and not as reproducibly good or do well when you fix them surgically. For these, I do non-weight bearing for 6 weeks. And if the patient is obese, I may even add 6 more weeks after that of an off-loader brace to give it the best chance to heal. Next slide. Tear location and blood supply are critical to deciding who we repair and how we repair it. And we went through the blood supply where the diagram on the right, zones 1 and 2 are more amenable to repair. Next slide. So this is a patient of mine, a 17-year-old male high school player, had a knee injury playing soccer. He was slide tackled, had a valgus force to the knee with a direct load. He complained of achy knee pain, sensation of instability, but also had loss of motion. So patient came with about 10 degrees of flexion, couldn't fully extend his knee, and he had pain with joint line tenderness and a McMurray's test. So next slide. Now, in this patient, 17 years old, we got to decide, well, what's the initial management? And acute traumatic tears often can still be treated with a trial of rest, ice, compression, elevation, getting into a good physical therapy routine. But this patient's a little bit different. He's young, number one. Number two, he has a block to motion, and he's experiencing mechanical symptoms. So right there, that tells me this is probably going to be surgical. Degenerative tears, I always try a course of non-operative management. So physical therapy, you can do a corticosteroid injection, PRP injection. There's some data that suggests that PRP can be helpful in arthritis, maybe not as much in that degenerative meniscus tear, but it's, if the cost is not a deterrent to the patient, it's maybe worth trying. Next slide. So this article is kind of a landmark study in the New England Journal of Medicine, and typically this journal is it sort of espouses non-operative management for a lot of conditions. But what this was a study in relatively young patients. I would argue that 30-year-old as a mean average really starts getting into that older demographic. But they looked at early surgery versus exercise therapy and physical therapy for 12 weeks. And what they found was that early surgery wasn't superior to the initial exercise and education plan. And at a year, they were fairly similar. And the non-surgical group always had the option for surgery later if they had these surgical indications like mechanical symptoms or effusions. But again, I think this is different because the patient population isn't truly that young. Next slide. So these are the true surgical indications. Obviously, if it's a severely displaced tear blocking motion, we need to do something for it. Tears with an ACL rupture, I'll present to you data that shows that treating these meniscus tears and fixing them at the same time of an ACL, the chance of healing is much higher. Mechanical symptoms, tears with a discrete traumatic etiology with recurrent effusions, and then persistent pain despite non-operative management. Next slide. And so this systematic review kind of looked at, it was in 2011, looked at the short and long-term follow-up following partial meniscectomy. And what they found was that there was a lower reoperation rate than isolated meniscus repairs. They also found that the medial meniscus had a higher reoperation rate than repairs of the lateral meniscus. And that's probably because of that lack of mobility I talked about before. They're more prone to re-tearing. The first point that I mentioned, that's why I stay up at night, in these tears in professional athletes, because although a lot of them should be repaired, you worry about having to do a second surgery because the repair, although maybe done well, maybe the patient was compliant or non-compliant, it still fails, and then they need another surgery. And then finally, we talked about ACL repairs in the setting of meniscus repairs in the setting of ACLs, and they tend to do much better than isolated meniscal injuries alone. So this next study, AJSM 2010, it was a level 3 study looking at a cohort of 81 patients. And basically this just tells you that after a meniscus debridement, the chances of arthritis were about 60% compared to 20% in the repairs. The return to pre-injury level in this study and the meniscus repairs were higher than in meniscectomies. And so this is sort of supporting what we've heard before, is that we want to limit the amount of arthritis and try to get our patients back to the field as soon as possible. Next slide. So back to our patient, this is his MRI. What the blue arrow is pointing at is that black structure sitting in the central notch of the knee. That is the bucket handle lateral meniscus that is displaced into the joint. That's why he had a block to motion, and so we ended up doing surgery. Next slide. And so if you look at the top left slide, that's looking into the lateral compartment, and the meniscus is blocking our view. If you compare that one to the bottom right picture, when I push the meniscus back with my probe, you can see now that's a normal meniscus, in between the two joint surfaces, the femur on the top and the tibia on the bottom. And so we got to repair that. Next slide. And so this is that bucket handle tear that I was talking about. This is a nice schematic. Next slide. And so first I take my suction shaver device, the metal instrument, and I create the bleeding in that peripheral capsule. So I roughen it up, kind of like sandpaper, try to stimulate as much healing as possible. And then next slide. Through a sequence of multiple sutures, and I'll go through the different repair techniques. I start kind of tacking that back to the peripheral capsule. And then last slide shows the final picture of the meniscus repair, where you can see it there, where it's normal meniscus, probably a good 10 to 12 suture fixation, and patient ended up getting back to full activity. Next slide. So the ABCs of meniscus repair are really anatomic reduction of the joint, of the meniscus. You need a strong biomechanical repair. So multiple sutures in a vertical orientation is biomechanically the most sound. And then augmentation with different sort of clotting factors where you can do abrasion, which I showed you, creating bleeding in the capsule. Trephination is taking a needle and doing the same thing. Marrow venting is this top right scope picture where, you may get a patient referred to you that said they had microfracture, but really if you microfracture in the notch where the ACL is in a non-weight bearing portion of the knee to create bleeding, it's almost like free PRP, and it's biologics to help heal that tear. Fibrin clot on the bottom right, if you look below my metal probe, it looks like sort of a lack of better analogies, is like a booger that you sort of, there's an old glass beaker and a stir that we used to do back in the 80s and 90s, and it's chilled, and when you take blood from the patient, you put it in the beaker, you kind of agitate it for about 5 to 10 minutes, it'll eventually clot into this glob of tissue, and we used to tuck that into the repair site to bring healing factors to the joint. And then finally, PRP can be done. The goal is to preserve as much meniscus as possible. And in so doing, we try to get every chance for the meniscus to heal. Next slide. So the repair techniques, there's the inside out repair technique seen on the left, where we literally pass the sutures from inside the joint to outside through an open incision. There's the outside in, which is really just a modification of that procedure in order to fix the anterior horn of the meniscus, because when you go from inside the knee, you can't get to the anterior horn. And then the all inside basically uses technology to repair the meniscus in a kind of simple one-stage fashion. Next slide. So starting with the inside out, we use low profile needles that allows perpendicular suture passage to the meniscus. That's what you saw in my 17-year-old patient. This is the gold standard for meniscus tears. You can have multiple points of fixation. You can put them right where you want them, and you can get easily 12 to 20 stitches into a meniscus, where you can't do that with the larger all inside techniques. The disadvantage is that there's an open incision on the medial and lateral aspect of the knee. You need a really skilled surgical assistant to catch the needles as you pass it, and it can be challenging. Next slide. The all inside, this is, if you look at the bottom right of the screen, the schematic there, it's almost like a harpoon where we poke into one part of the meniscus, press a button, that plastic button deploys on the back of the capsule. We then pull that harpoon out. We go to a second spot with the same harpoon, do the same thing. It's got a second peak implant that deploys. And then when we pull it out, there's one stitch. And when you pull the one stitch, almost like a Chinese finger trap, it'll tension it down. And so you can do multiple all inside techniques. The true downside is hardware irritation in the back of the capsule. I've seen some devastating neurovascular injuries where the peroneal nerve on the lateral compartment or the artery in the back of the knee have been damaged. And so it's not, it can be dangerous, and they're extremely expensive. So industry loves it. You have to use 4 or 5 of these. They cost $700 to $1,000 each. And so the sutures with the needles on the inside out are much cheaper. Next slide. And then finally, outside in is a technique for the anterior horn. You use 2 needles to pass the suture. Suture goes through one needle, you have sort of a ringed looped wire that catches that suture and you pull it back out the other needle, and then you tie them and you close that space. Next slide. And so this meta-analysis in 2023 essentially confirmed that British Journal of Sports Medicine article back in 2018, essentially looking at 32,000 patients. And again, the meniscus repair had lower progression to knee arthritis, 6 years follow-up compared to meniscectomy. And so that's why we do these meniscus repairs. Next slide. In this study, looking at lateral meniscus tears in young patients, it was a retrospective cohort study, 217 patients, 25 years of age or younger. And what they found was there was an increased trend in arthritis in patients treated with meniscectomy compared to meniscus repair. And primarily the lateral meniscus, like I said before, is uber critical because it helps establish more joint congruity on that lateral compartment where you've got the tennis ball sort of sliding over the dinner plate. It allows more congruent anatomic anatomy there. Next slide. Now, when we looked at meniscus repairs in professional soccer players, this study is actually pretty interesting. And again, it sort of confuses what is the ideal treatment choice for these patients. This was just done last year, mean age of 23 years of age, and they looked at meniscectomy versus repair. And what they found was, of course, meniscus repairs failed 15% of the time, more so than the meniscectomy, where you're just taking the meniscus out. There is no significant difference, 5 to 10 years for professional sport participation between these two surgeries. But I would argue that you can only play professional sports for so long. The question is, after that, who's going to get arthritis if you do a subtotal meniscectomy? They may love you when they're 23 to 28, but when they're 35 or 40, we've actually seen lawsuits from professional athletes for orthopedic surgeons who've done meniscectomies and they've gone on to have shorter careers and developed arthritis. And so again, another reason why it's a little bit nerve-wracking as the treating physician. Then lastly, return to play with the meniscectomy is faster. So you have agents, you have coaches, you have people pushing you who are paying their payroll to potentially get patients back or back faster with a meniscectomy versus being out 4 to 6 months with a repair and then having that 15% chance of it failing. Next slide. This systematic review basically just compared surgical repair technique, looking at the inside out, which I said was the gold standard, versus the all inside. And they basically found that the inside out and the all inside had really no significant difference in clinical or anatomic failure rates, and the complication rate was fairly similar. Next slide. But this study, sort of supporting why the inside out is sort of our treatment choice, it looked at repairs in athletes. And they found that the all inside technique showed a statistically significant increase in failure rate compared with the inside out technique. Particularly medial meniscus repairs utilizing this device shown had a significantly higher rate of failure. And so if you are going to do a repair, primarily in a professional athlete, or particularly in a professional athlete, an inside out repair may be more beneficial. Next slide. And so we talked about augmentation. This article just supports that we need to be doing more than just putting sutures across the meniscus. If in this study, there's a 100% healing rate when we did bone marrow stimulation. And so the tear patterns that are a little bit more concerning that they may not repair or heal, like radial tears or complex root tears, will add marrow stimulation or procedures such as that to help with repair. Next slide. So second case, this goes into just one final surgical technique when treating meniscus tears. It's a 25-year-old patient of mine, had a long history of knee pain, had a meniscus repair in 2013 of the lateral meniscus, had recurrence of symptoms in 2018, basically had a subtotal or near complete meniscectomy. Next slide. On physical exam, it was really just significant for lateral joint line tenderness, had persistent pain with just everyday activities of living, couldn't get back to playing sports. Next slide. Radiographs surprisingly look really good. So on that left x-ray, the lateral compartment by the fibula, you can see the space between the two bones is fairly symmetric to the medial compartment space as well. So despite living 8 years, actually, when the surgery was about 7 years without a meniscus, this young male is lucky he did not develop a lot of arthritis at that time. Next slide. And so this is his MRI on the left and a normal MRI on the right. You can see there's no meniscal tissue. That black bow tie, that black triangle is missing completely. You can also see the tibia right below where that meniscus is missing is increasing signal with bone bruising. And so the bone is seeing more stress because the cartilage is thinning. Next slide. And so for this patient, the top three pictures essentially show that there's no meniscus at all. Between the two bones, you don't see any meniscal tissue. And then the bottom two pictures show a meniscus transplant, a meniscus allograft that I did to help preserve the patient's cartilage and for the longevity and preservation of his knee function. Next slide. And so meniscus transplantation, although it sounds cool and you're like, why don't you do it for everybody? Just put a brand new one in there. It's not that cool. And so the studies show that it's not that cool. And so I did my residency or sorry, my fellowship at West Point. And let's say you have a young cadet freshman who tears his ACL with a bad meniscus repair. You try to repair the meniscus, but it fails. You then have to take some of it out and they're living without a meniscus. In those scenarios, our hands were tied, and so we did a lot of these meniscus transplants. And although they're good for the first 7 to 8 years, they tend to shrink up because it's dead tissue, and they aren't a good long-term solution, especially for active patients. Next slide. And so after this surgery, we locked the brace and extension. I actually let them ambulate because in putting weight on the knee, it'll compress that junction of the meniscus allograft and the capsule and actually encourage healing. I do limit the range of motion because we know in deep knee flexion, the posterior horns of the medial and lateral meniscus get distracted or pulled apart from the capsule. And so that's kind of my first 6 week protocol for the patient. At 4.5 months, the patient achieved full range of motion, didn't have much joint line tenderness, and was returning back to some low impact gym activity. And in 6 months, we discharged them from therapy. Next slide. And so the indications for this procedure are a complete meniscus deficiency where they're younger than 50 years old, because older than 50, you can do a partial knee replacement or a knee replacement. And they have to have pain. We don't do it prophylactically. If we take their meniscus out, we wait for them to develop pain. And then if they have pain, we can offer them this procedure, which is size matched to their anatomy. Next slide. Contraindications are inflammatory arthritis like rheumatoid or psoriatic arthritis, if they have ligamentous deficiency, if they're obese, if they had cartilage wear or even diffuse arthritis, and if they have malalignment that needs to be corrected with osteotomies prior to this procedure. Next slide. And so these are just different surgical techniques. The first two are typically done for the medial meniscus because the relationship of the anterior horn and the posterior horn isn't as critical to be perfect. But the lateral meniscus, since the roots of the meniscus are so close to each other, we want to keep that relationship. And so we use a bone bridge or bone block to kind of keep it at a fixed distance. Next slide. Brian Call out of Rush in Chicago looked at his outcomes and essentially showed that there's about a 70% survivability at 10 years. The medial meniscus lasted a little bit longer, but not statistically significant. Patients do get better. They get better for the short term, but inevitably they end up with recurrent symptoms, and the reoperation rate is not small. Next slide. And so in this case series out of AOSSM, essentially it showed exactly what Brian Cole showed, is that the survival rate at 5 years is 87% and only 70% at 10 years. Next slide. And so this one's interesting. It's meniscus transplants in collegiate and professional athletes. It's a 17 patient cohort. Again, I'm not sure I would offer a meniscus allograft in a professional athlete. That might be better in somebody else's hands, but it's an interesting study nonetheless. And it basically showed that the reoperation rate and the failure rate is extremely high in this high level athlete. And so it's probably not the best option for these patients, but in a pinch, it can be offered. Next slide. And so we want to look, how can we make this survivability better? And this recent study suggested that instead of using fresh frozen meniscus allografts, which can be stored for a while, maybe getting fresh meniscal allografts, just like we get fresh cartilage donors, within 21 days after the patient is deceased. We may need to be doing this for our meniscus allografts to maintain cell viability and the mechanical properties. Next slide. And so after all that tedious, painful orthopedic procedural talk, now we get to the exciting part, which is the PT protocols for meniscus repairs. It's going to be short-lived because there's not that much data, just like Michael Irving's excitement about Miami. Sorry to you Miami fans. Next slide. So, I really tried to dive deep into like what is out there, and I'd be happy to hear any of your sort of guidelines and data that you're utilizing. But this consensus statement is really the best thing we have going from the US and the European AOSSM. And essentially, it found that you really have to tailor the bottom left bullet point. You have to tailor your surgery type your rehab to your surgery type. So in a repair, you got to understand how tenuous was the repair? How well did the repair go? What type of tear was there? And really use criterion-based protocols and kind of getting away from that time-based progression and doing more of a functional milestone and safe progression of load and motion. Next slide. And you can see from this consensus statement that there's only one question out of the 19 that they asked that received a grade A recommendation. The rest were, suggestions at best, and a lot of them have no conclusion. And so I think emphasizing again an individualized plan with functional milestones where the surgeon is communicating with you, the therapist, and make a plan or rehab protocol that makes sense for them. Next slide. And I know that sounds kind of sort of um, anecdotal and sort of soft science, but I did try to find some evidence-based studies looking at why we do what we do for different meniscus repairs. And this study was actually really interesting in Journal of Orthopedic Surgery and Research, just done in June of 2025, basically looking at evidence-based guidelines on tailoring weight bearing and range of motion to the tear type and the individual injury. And it tells us when to progress weight bearing, how much weight bearing, and why. Next slide. And I learned a lot from this slide. It's actually, or this illustration. It's really interesting. A and B are the steady state intact meniscus. And basically what these arrows are showing is the vector force with full weight bearing on the meniscus. And A is a sagittal cut, B is the axial view of the meniscus. And so when you get to C and D, I think one of those red lines is actually in the wrong orientation, but they're looking at horizontal and vertical tears of the meniscus. And you can see that in D, that horizontal tear, that weight-bearing vector is compressing the tear. And so any weight-bearing vector that is compressing the tear and not distracting at our repair site is where we will weight bear the patient. In E, that kind of gold standard vertical tear in line with the fibers where you can get nice sutures perpendicular to that tear. When you bear weight, you can see the vector forces from the capsule and the central portion of the knee are compressing your repair. And so in those patients, I'll weight bear them right away. And then in F, you're looking at the dreaded radial tear. And you see all the vector forces are directed or pulling away or wanting to pull that repair apart. And so in my radial tears, I'll treat them differently than my other tears. So in summary, now you can go to that, that's fine. In summary, rehabilitation recommendations from me are more based on the different types of tear patterns and how well I get a repair. And so for most tears, vertical, horizontal mattress, bucket handle tears, and meniscus allografts, I'll have them bear weight right away. I do limit range of motion 0 to 90 just so that you don't distract that posterior horn and pull your repair apart. And then for me, root tears at the anterior and posterior roots, as well as radial tears, I will treat with non-weight bearing for 6 weeks. So the meniscus is critical for knee function. It can turn into something so simple as a meniscus tear and quickly devolve into cartilage wear, arthritis, and then you're talking about a knee replacement in someone who is can be relatively young, and it's a problem. Not all tears are created equal. Even there's a significant difference just between the medial and lateral meniscus. Multiple repair techniques exist. It's a challenging procedure, so it needs to be done in the right hands. The inside out repair is the gold standard. So if your patient comes to you with a vertical incision over the medial lateral knee, that means they had an inside out repair, and that's the best chance of that repair to heal. Bone marrow venting or some sort of biologic augmentation should be considered. And then meniscus transplant really equals what is a salvage procedure. It's a relatively high failure rate. The longevity, we're trying to work on that. And it's really best fitted for that 30, 40-year-old who's willing to modify their activities, not do impact aerobics, and is having joint line pain with not a lot of arthritis. Next slide. So that's all I have. I hope it's sort of answered some of the questions you may have, and I'm looking forward to learning from you all as well. And thanks for being here tonight. And next couple slides are the references, and I'll take any questions.
All right, thank you very much. And we've got a couple questions already coming in, either in the chat or the Q&A. For those who are on, let's have you put the questions in the chat. Actually, it'll just be easier to have it all in one place. So I'll start with the Q&A questions that came up. The first one is, are ramp tears easily diagnosed on MRI, or are they missed often?
That's a great question. I think a well-trained radiologist will point that out to us. I think sports fellowship trained orthopedic surgeons, we know to look for it. Some, remote areas, a general community orthopedist may not know to look for it. And so what you want to look for, you can see that vertical signal at the meniscus capsular junction on the sagittal view. Or oftentimes you see bony edema on that posterior medial plateau of the tibia where the bone is lighting up. And it's something to look out for because in ACL injuries, often we see lateral compartment bone bruising, not medial compartment. So if you see that vertical signal with a bony edema, then you're looking for a ramp tear.
Another question from the Q&A, are there any augmentive type procedures other than the biologics you listed that are being considered alongside meniscus repairs currently, analogous to an LET or ALL with ACLs?
Not from a biologic standpoint. We've kind of run the gamut through BMAC, PRP, liposomal stem cells. Not many people are doing those things. I think the fibrin clot has sort of gone away because it's tedious. Oftentimes, by the time you pull the scope out with the fluid, it kind of pulls out from where it belongs. I think capsular stimulation with trephination, abrasion, the microfracture in the notch, and then also looking at the patient's alignment and making sure that they're not severely varus or valgus, and possibly adding a concomitant osteotomy to offload that meniscus repair.
Excellent. And we had a question in the chat whether the slides would be available. I will be sending out a recording of this presentation for everyone who has registered. So you're going to have access to all that. And we'll talk about maybe getting like a PDF version of the slides if that's helpful as well. Another question, you mentioned repairs for radial tears. This person is curious, what's your decision for possible repair of a radial tear versus just moving to meniscectomy, as it won't stay viable?
Yeah, I mean, I think, again, technically demanding, but in my hands, especially if they are middle age or younger, if it encompasses more than 50% of the meniscus, you're sort of, you're kind of not doing the patient any favors if you debride and take out most of the meniscus. And so I will, with the technology that we have, all inside instrumentation, inside out repairs, I'll try to repair most meniscus tears, especially radial tears now. There's been more evidence to support that, but I'll counsel the patient appropriately and say, listen, we're going to do the best we can to get this to heal. We always have the option to go back and debride it 6 months, a year, 2 years down the road if it doesn't heal. But personally, I'd rather have a chance for it to heal because I think the long-term longevity of the joint is better with as much meniscal tissue as possible.
Fantastic. And you brought something up earlier that I think a lot of the PTs on here may benefit from. And you're clearly a surgeon who is interested in having dialogue with the rehab, with the therapist and the team. How do you like that to go? Are you usually corresponding via email? Are you texting? Are you giving them the op report? Or, what sort of things would you encourage the PT to be asking if they're facing a meniscal repair from a surgeon who isn't you?
Yeah, I mean, personally, and I'm being quite frank, it's not because I'm on this webinar, is it's just I'm old school. I'm not a good texter. I don't do social media. I just like to talk. And so a lot of my therapists have my cell phone number and a simple text message or even a phone call. I'd rather do that than patient have the wrong rehab protocol treatment and we damage a repair or we do something wrong. And so I think open communication is critical. And if there's a surgeon that's not up for that, I kind of question their intentions. And so that's just how I handle what I do. And even an email is fine. I think the patient doesn't often come with the protocol. But I do give my patients the protocol, the operative report after the fact can always be brought to the physical therapist if they expressed interest in doing that. Um, but again, I think it's just open line of communication. And Ben, you can share my cell phone number with all your local therapists. It's not a problem at all.
Right. We have another question. What can we do to get surgeons to send us their op reports with the script for VT? As you stated, it's incredibly useful to understand what kind of repair and how the repair went. It sounds like the summary there is try to build a connection, get text basis, email basis, phone call, and try to go that route. Is that what you'd recommend?
I think for me, I'll send them with an operative report from here on out if you'd like. I also think that I think the patient should come with the protocol at the minimum. But when I write a referral, I put just like when I order an MRI, it's not fair to have the radiologist kind of try to find the needle in the haystack and try to find what I'm looking for. In my referral, I will say it's a supraspinatus tear, anterior third, it's a medium-sized tear with a subscap repair. And I use a shoulder as an example because I always get that question. But for the knee, I'll say, listen, concerned about meniscus repair, it's tenuous, it's a radial tear, go slow, and just kind of use directives in my referral.
Great. Final question. Looks like, could you talk about how much you changed the weight bearing progression after surgery with radial tear versus longitudinal tears?
Um, so with radial tears, unlike the kind of that root tear where we see more often in patients with some arthritis or who might be obese, where I'll do an offloader brace for another 6 weeks to kind of give me an insurance policy. Radial tears are kind of let them go. So it's 6 weeks where they've been fully non-weight bearing. I don't mind a 2 week kind of progression, 50%, 100% weight bearing after that. And so I will let them progress with weight bearing. Am I frozen, Ben?
You were there for a little bit. I think you're back. You want to try that one more time?
In summary, I think the radial tears, I'll let them go about 50% partial weight bearing between 6 and 7 weeks, progress to full weight bearing 7 to 8 weeks, and then I sort of let them fly. The root tears, it depends. If they're obese or they have a moderate amount of arthritis, I'll get an insurance policy. I'll put them in an offloader brace for an additional 6 weeks to kind of give less kind of weight and pressure on that meniscus repair.
Fantastic. And one last question was asking if there are any specific preventative measures from the research that you've seen that a PT can use to reduce the risk of meniscal tears through modifiable factors such as strength, neuromuscular control, or movement mechanics.
I think that's a great question. And honestly, I don't know the answer to that. I don't know if, just like ACL prevention injury from a meniscus standpoint, um, I'd be happy if any of you want to chime in if you've heard of something, but I don't know anything offhand.
All right. Well, thank you again, Dr. Giuliani, for taking the time this evening. Absolutely incredible presentation. Oh, there's one more that snuck in at the end here. Are there any certain criteria you would want to see before progression from double limb to single limb loaded flexion after the initial weight bearing directions?
I mean, I think just quad control, like anything else, making sure that they have, they can do this straight leg raise unrestricted for, probably, 20 plus times or so. Make sure that they're getting their isometric strength of their quad and that they're safe to progress with full weight bearing. But I guess the answer would be quad control.
Fantastic. A world-class presenter, world-class presentation. We really appreciate your time. Thank you all for tuning in, those in the live course and in the recording. Really appreciate it. Stay tuned for the upcoming agenda for the rest of this year. It's going to be an awesome lineup. So thank you guys again. Enjoy the rest of your evening. Dr. Giuliani, really appreciate you.
All right. Thanks, guys. Have a great night.